Good morning. Welcome to the Town Hall. Lovely turnout for a beautiful day, and the weather forecast for this weekend looks incredible. So let's jump in. Let's begin with our territorial acknowledgement. Always important, but feels more vital that we show individual support for all of our communities at this moment in time in our country. We acknowledge that we are gathered today on the treaty territory of the Mississaugas of the Credit and the ancestral and traditional lands of the Anishinaabe, Haudenosaunee, Ojibwe, Chippewas, and Huron-Wendat nations. We've made a commitment to include an educational piece as part of our territorial acknowledgement. There's no test, but in previous town halls, we've given you information on our Aboriginal patient navigator associated with our cancer program. And on the last one, we presented Sinai Health's smudging policy, which facilitates smudging ceremonies on both of our campuses. In line with our value of inclusivity, the Diversity, Inclusion, and Wellness Department will soon be offering training on inclusive service with a module specifically focusing on Indigenous peoples. If you or your groups are interested in receiving that module and that training, please contact the Inclusion Wellness Department of the hospital, and by all means, do so. So my update. New leadership appointments. What a nice place to start. Did Erin make it? Oh, we'll start with her anyway. Her ears are burning somewhere. Thrilled to announce 3 new leaders. Some are new faces, some are older faces, but all in crucial roles. First, we're delighted that Dr. Erin Kennedy has been selected as the head of our Division of General Surgery. For those who are not close to general surgery in Mount Sinai Hospital is a crucial division. It's a very large program in of itself, including cancer surgery, mainly colorectal, breast cancer surgery, and probably the country's leading inflammatory bowel disease surgical program created by Zane Cohen, and really leads our IBD comprehensive care program. And Dr. Erin Kennedy is a general surgeon, one of our senior surgeons, and a specialist in quality improvement, leading our NISQIP work. So we're thrilled that she's starting her first 5-year term. Hopefully this will be 10 years. Also delighted to introduce Dr. Heidi Schmidt. Dr. Schmidt is taking over the leadership of JDMI, Joint Department of Medical Imaging. Medical imaging is a single professional academic department that includes all of UHN, Women's College Hospital, and all of Sinai Health System. So the professional group is one. Patients typically experience a unified program in that patients will be referred for an imaging procedure where it makes the most sense, and it gets read where it makes the most sense, and that's not necessarily in your institution of origin. Operationally, we're distinct, but we're very much related. When we buy CT scanners, for example, it's very nice to have the heft of JDMI behind us, and that helps dramatically. Dr. Schmidt is a radiologist based at Women's College Hospital. She's been in the interim chief role for some time, was selected based on a competitive open search that was done by the 3 hospitals together, and we're absolutely thrilled. We've gotten to know Heidi over her period of interim status, and she's an exceptional citizen. She gets Sinai Health, and we are delighted that she'll be leading all of us. Heidi is where? She's on vacation. Work-life balance. She gets it. Next, I'm delighted to introduce someone who hopefully will need not much introduction here, but we're delighted after Dr. Shuley has completed his tenure again. We did an open international search for our pediatrician in chief. For those of you who aren't close to the 17th floor, you're scratching your head. We have pediatrics. We do. We have an important, large pediatrics department because the neonatal intensive care unit on the 17th floor at Mount Sinai Hospital is the country's largest neonatal intensive care unit and the country's highest acuity neonatal intensive care unit. The professional staff, the physicians, are pediatricians who are neonatal intensive care specialists. It's a large group. It's an academically spectacular group. Initiatives such as FICARE came out of this group. So they're not just leading locally, but they're actually changing how care is delivered to the most vulnerable patients, newborns that are at ridiculous weights of 500 grams less. Unimaginable, but we do that just one floor down from where we are right now. Dr. Shaw is a Canadian and international investigative or scientific leader, population health systems, very much a large profile in the delivery of care and quality and metrics, both in Canada and on the international scene. Dr. Shaw has been with us for several years, and we're delighted that he's been selected and is our new pediatrician in chief. So Prakash is here. Is Jennifer here? Jennifer's here. Also delighted that we've had operational growth as well. Especially on this campus, ambulatory care is enormous, and you wouldn't say it's organized. Not yet, right? Ambulatory care is a huge part of what this hospital does. Probably close to 500,000 visits a year when you factor everything in, between all of our programs from women and infants to diabetes endocrinology to GIM to family to psychiatry, go down the line. It's frankly not been an area that we have at an institutional level focused on. We have left it to groups, individual practitioners and groups of practitioners to do their own thing. In 2020, that's not an acceptable approach. We're entering a digital universe. We're entering a universe where communication and coordination is expected to be at a level that we're not even close to attaining. And we'll never get there in ad hoc one-off steps. So Marina's in the front. At the executive level, there's been sponsorship of an enormous amount of work to redefine our ambulatory care enterprise. And it was immediately recognized that we need leadership that comes into work every day whose mission, passion, goal, achievable goal, is to do what we've just said, is to coordinate and create an ambulatory strategy for the entire institution. That's really soup to nuts, from a digital strategy, a booking strategy, what we do, where we do it, and how we do it. So Jennifer comes to us with a wealth of expertise. Were you at one point at Bridgepoint? Everybody was at one point at Bridgepoint. We're delighted to have you back, and many of you who have not met Jennifer will absolutely meet Jennifer in the near future, so thank you very much. Strategy 2025 update. We're not presenting the new strategy today, but we're explaining that we will be presenting the new strategy very soon to let you know that the work that many of you in the room have helped us with, and thank you, whether it was in focus group, in interviews, in the strategy hives, those big sessions we did at Bridgepoint, we have hit the point where we have our draft strategy. It's no longer draft, it's actually been through board a week ago and blessed by our board, that will take us from 2020 to 2025. You should be getting used to us rolling things out. Your lanyards, when we did purpose, values, legacy, we'll be rolling out a communications approach to explain what the strategy is, so you'll be able to understand where all of us fit into it in terms of the next 5 years. It will very much drive our priorities and our focus, our investment over the next 5 years. That's a teaser. We think it's pretty good, and I'm sure you will as well. Handing off now, brief introduction. COVID-19 or novel coronavirus. This institution, like all institutions, was faced with the discovery of a new virus, a new threat, with the context that especially in Toronto, so many healthcare workers had experienced a novel virus in a very different circumstance, and that was when SARS came through, and this institution was one of those that was an epicenter institution. Many lessons were learned, and this doesn't look like that, and you'll learn why in a minute. Overview, we have created an executive sponsorship model where Maureen and Shanling and Jane Merkley are the executive sponsors that have charged and created a committee led by Dr. Jenny Johnstone, Kate Wilkinson. If you look at the communications you're receiving twice a week, scroll down to the bottom, you'll see those two names. And that is the working group that is leading our planning and preparedness for COVID-19, novel coronavirus. We're coordinated with our peers, we're coordinated with the province, we're coordinated with PHO, Public Health Ontario, PHT, Public Health Toronto, we're working with the OHA, we're reading the blogs and the WHO, et cetera, et cetera, et cetera. So the process here has been very organized, very comprehensive, and I'm very confident in what we're doing. Part of that is to give you some insight into what it all looks like and what groups are doing. And so Jenny and Kate will open that up for you now.
Hello. For those of you I haven't met, my name is Jenny Johnstone. I am the Infection Prevention and Control Physician Lead and an infectious disease physician. And I'll just be providing an overview of COVID-19, and then Kate will talk a little bit more about the operational impacts here at Sinai, and then Alison Arnott will be talking about the strategy around mask fitting and a few other things related to staff. And we can certainly ask questions. I'm not sure it'll be at the very end, or I can also hang around at the very end as well if you don't want to ask them publicly. So just to back up, infectious disease physicians and other individuals receive sort of daily updates multiple times a day about any outbreaks that are occurring around the world, whether it's humans, animals, plants even. And so we always have a finger on the pulse of what's happening. So going back to December 23rd, there was the first social media reports that something was happening in Wuhan, China, in the Hubei province. And so the concern was that there were these unidentified severe pneumonia cases in a few of the ICUs in the hospitals. And it really, again, came from social media saying something might be happening. And they do severe pneumonia surveillance in China for obvious reasons related to SARS. And so we, as a community, saw this right away and started to watch it carefully. And there were sort of these updates, and every day, including on Christmas Day, we were watching. And again, it seemed rather small. There was a notification from the ministry, I think it was the end of December or early January, saying, yes, we are also aware of these reports, or unconfirmed reports coming out of China, and specifically Wuhan. And then it sort of stalled around 40 patients identified, but then quickly escalated. And I think that we were all watching, is this going to explode, or whether is this going to go away? Because most times we see this happen several times a year and it just kind of goes away. So we were watching it carefully, but again, all of a sudden one day it just jumped in terms of the number of cases within Wuhan, China. It was at that point that I happened to be meeting with our executive for another reason, and I said, so something's just happened, and everyone was aware that this was trickling in the background. And immediately our executive said, what do you want? What do you need? What do you need? What should we do? And the next day we arranged a tabletop exercise. I should mention that we were always screening for respiratory symptoms from China because of avian influenza, so our screening didn't have to change, but a matter of walking through what we would do. After that tabletop exercise, the next day we had a patient return from Wuhan, China with respiratory illness. So we were very prepared to receive that patient. It executed perfectly. They were negative, otherwise you would have heard about it in the news. But again, we were very prepared, and we've continued to then implement a structure as Kate will talk about a little bit further. So as of I'm sure you have information overload related to coronavirus. It is everywhere in terms of the sensory overload and inputs. But just to sort of update as of today, because it seems like every single day or multiple times a day we get an update. But we know there's over 75,000 cases. 99% of those are in mainland China. There are a number of other countries that have reported cases, Canada being one of them, which we've had 8 cases so far. Newly identified yesterday or last night was Iran, was the first 2 cases were identified in Iran, and they were deaths. And so I think that we assume that there's more transmission occurring there. On the weekend, another notable country added was Egypt. That was the first case of novel coronavirus identified in Africa. So again, we're watching very carefully because, watching to make sure that that is contained and what have you. But most of it has been, again, 99% of it has been in mainland China. Ontario specifically has had the 3 cases, and I think we're now beyond the 14-day mark from the last case, which was in London, Ontario, and there have not been secondary transmission related to any of those cases. BC continues to have some cases, so they've had 5, and the last one, I think it was last Thursday or Friday. But again, we haven't seen large clusters with sustained transmission within Canada. In terms of more federally, we've had 3 flights return from Wuhan, China, so and they have been in Trenton, Ontario, on the basis there, and we're getting towards, I think we're almost at the 14-day mark related to those passengers who have come back. So again, the 3 flight loads, and none of those individuals have tested positive. They would communicate that, so I think that's a good news story. In terms of the disastrous cruise that I'm sure you've heard of, the Diamond Princess, which is the cruise ship that has been stationed off of Japan, which it's like an outbreak. From an infectious disease perspective, it's an outbreak nightmare in terms of how that has transpired, and I think an example of what not to do now and trying to quarantine on a cruise ship. However, there are individuals, the Canadians on the Diamond Princess are being evacuated and are coming to Cornwall, Ontario, and they're due to land, I think it is tomorrow, as they updated, correct me if I'm wrong, but I do think that is a higher risk situation than what we've seen so far in terms of, I think the expectation is that there will be people who are positive, because if you're watching the epidemiology, they're diagnosing almost 100 people a day from that cruise ship. And so I think clearly there's ongoing exposures that are occurring related to those individuals, despite the fact they said they were quarantined. And I think there's new reports out that the infection control measures that were input were obviously not up to the standard that we would expect, say, on an outbreak on a unit or hospital situation. So we will be watching that very carefully about what's happening there in Cornwall, but there is a huge amount of resources federally that have gone into Cornwall, and there's tons of people on the ground there ready to receive these individuals. And they will be there for a 14-day quarantine. So again, this is just a heat map showing, again, by far, it seems like it's everywhere, but really and truly, 99% of these cases are mainland China. And then there are cases pretty much throughout the world. And I would say that the places that haven't reported cases, if you look, it tends to be countries that don't have the infrastructure that you would expect. So if you imagine you need to have very active screening in hospitals to identify them, you have to have the testing methods available, you need to have public health infrastructure to follow. And so I think there's a number of countries that are notably have zeros, and I think many of us feel that those countries that have 0 cases are actually more concerning than the ones that are reporting very carefully and diligently. So, obviously we're just trying to track all of this very carefully, and I think in the next week or 2 we'll be able to tell whether or not this containment strategy, which is really and truly an unprecedented strategy for something that's this communicable disease illness at a country level to try and contain an illness, we'll see whether or not it's successful or not. And again, we'll see. Just a case definition. So this is the case definition that we are using right now in Ontario, as well as in Canada, and as well as the US. It is any person with fever or acute respiratory illness, and traveled to mainland China in the last 14 days before onset of illness. And again, if you think about it, that's just because over 99% of the cases are from that area. And the ones that we are tracking in the other countries are generally linked to established clusters, so they know who the source was and they're just watching the close contacts carefully, or a close contact of somebody who is sick, so either a confirmed or probable case of COVID-19. With that, I will turn it over to Kate, and again, I'll be available to answer questions related to the content of COVID-19.
Thanks, Jenny. It's been an absolute pleasure working with Jenny and the other members of the task force and the working groups. There has been just a tremendous amount of work that has gone into the last couple of weeks. It's really only been 4 weeks since we brought together a group of people and took a look at all of the things that we needed to do. That tabletop exercise was very powerful. We identified a number of things that we had in our archives from work that we've done in many other similar clinical situations, and to bring them up and take a look and see how applicable they still are, what are the things we needed to work on. And so we mobilized very quickly a number of working groups, and I just want to let you know, even though we have one that says staff protection, all of these working groups are primarily focused on the safety of people, primarily the workers in the organization, our physicians, our learners, and of course our patients as well. As Gary mentioned, we are reporting to Jane and Maureen, who are obviously participating in working groups themselves and also at the steering committee level. Other key members that you should note at the steering committee is our joint occupational health and safety co-chairs. So that is Bob Allen and Leah Kabaroff, who are there and also liaising back with the committee as well. And they had a meeting, I believe, yesterday. And then each of the working group, we have a number of individuals that come and provide updates, and then they bring information for decision making to the steering committee. So we have a patient screening team that is going through systematically through the organization and looking at what are called points of entry for the organization. To Jenny's point, that obviously from a very early days and also on a regular basis, ED are expert at screening for communicable diseases and particularly from travel from other countries, and frequently do so. And also, this is influenza season, so we're looking for people who would generally have seasonal flu as well. However, there are other areas that do not do typical screening, but interact with people who are coming into our organization. So in addition to the screening in the emergency department, we also wanted to quickly talk to the teams who are seeing people in our family health teams. And then from there, we have, using the definitions that we're still working with for the province, is to say we've got both active and passive screening being rolled out for different areas. So that requires, in some cases, some physical changes to the way that we, patients and staff, are interacting with one another, because we are not in a situation where our staff are wearing personal protective equipment, but it does require. So you'll see some areas are putting up physical barriers that allow us to do that initial screening from a safety perspective, so that they're behind a barrier. So those are physical things, and it's that's one thing to do. In addition to that is walking through the process, and then what would you do if you had somebody who screened positive for travel but was well, and how do we track those individuals throughout the organization? So lots of activity going on there. Jennifer and Carolyn are helping to sort of drive that work, and that's across site as well, across to Bridgepoint too. And we're also at the family health team in Vaughan. So we're capturing all of our areas where patients enter into the organization. The aerosol generating medical procedures is a specific group who are looking at how do we protect individuals during those procedures that create aerosol, in terms of, we know from SARS, and we know a lot from 17 years ago and other things since that have popped up, that when healthcare workers get sick, it's because they're either they don't know that somebody is sick and they're not protected and they're not wearing PPE, or they're not wearing the right PPE during some of these procedures. So this group, led by our physicians primarily, and also in support with Leanne Ginty and Cara Ronald, are looking at how do we operationalize those very step-by-step processes to ensure that staff are safe. And that's including looking at specific equipment that we need to have on hand, ensuring that we have the right physical location where these procedures are done. And just so you know, those 8 people that we have tested in our emergency department, they all get tested within a negative pressure airborne isolation room, because again, anytime that you're going anywhere close to somebody's airway, you're more at risk, and the staff were wearing PPE. Thankfully, they were all negative. I'll skip over the staff protection group because Alison's going to come up and talk more specifically about their work, because that's key. And just from an infrastructure perspective, a key component of our preparedness for any airborne contact droplet condition is our infrastructure around our airborne isolation rooms. And so we have our rooms on a preventative maintenance and ongoing maintenance program on a monthly basis, but we've also been bringing in external providers to come in and do additional testing and maintenance to make sure that all of our rooms are up to spec and are working according to the specifications we require them to be. And then our final group that I'd like to just speak to is incredibly important, and we realized very early that communication was absolutely key to all of you, as part of today's session is about, is making sure that you have up-to-date information, that it's from reliable sources. There is a lot of information out of there. There's a lot of speculation about what's going on. And we know from Bob, who's sitting up there, and the experience that we've had from working with teams during other similar situations like SARS, is that information as we know it is important. We also need to tell you what we don't know. What we do know, we can tell you, but what we don't know is we have to sort of accept that there are certain things. And there are certain elements to people having a resilience during these times that we need to be aware of. We've had some teams that have really sort of raised the red flag and say, we're struggling with this, we need some extra help, and we've been sending in teams to sort of meet with them and work through their questions and do our best to support them. And those have been very effective as far as we know, and so it's really important to pay attention when people are feeling stressed and they need additional support. And they are the sort of canary in the mine. If they have concerns, we need to pay attention to them. So we are doing our best to provide tips and things that everybody can use during these times, but there are some teams that need some special support and attention as well. So we're again here for questions if there's any questions. And I think this week, Bob, we're putting out information specifically about each one of these working groups and some of the key things that we're working on this week. But I'll hand over to Alison that has more specific information about staff protection. Thanks.
Good morning, everyone. So I am going to try and, as quickly as I can, give you information about the Staff Protection Working Group and the activities around that. And then I'm going to invite Kate and Jenny up to just answer questions, and we'll do that right after I have finished. I will try to make this as quickly as I can to give you as much time as possible for questions. I will also try to anticipate your questions and answer those in my talk. But I could talk about this all day long, as it has become my full-time job in the last 2 weeks. So I just first of all want to really stress to you that it has become exceedingly clear to me that the safety and protection of our staff is absolutely the number one most important priority of this organization. It has been made exceedingly clear to me that it is the most important thing to Gary and to Jane. And I can also tell you that because I personally am on 3 separate committees about keeping you safe from coronavirus. We're spending a lot of time and effort to make sure that we are anticipating what you need to stay safe. Having said that, I also just I always just do a little plug to let you know that you are hearing a lot about this in the media. We are spending a lot of time and effort on this. We are spending a lot of time thinking about it. We do not have an outbreak in Toronto. Coronavirus is not an imminent threat to your safety in Toronto, despite what you are seeing in the media. My kids are coming home from school. They're very worried about it. There's all kinds of, rumors. There was a kid at this school who has it. There was a kid at that school who has it. No, there wasn't. There were 3 people in Ontario. All of them are recovered. All of them are feeling well. All of them are back to their normal life. We have no clusters. We have no sustained spread. Everything that we are doing now is preparation, not management. When we start to manage an actual problem, we will let you know. So for now, the most important thing for you to know is that we are in a regular cold and flu season. And in a regular cold and flu season, since we're all healthcare workers, we know that the most important thing you can do is wash your hands, wash your hands, wash your hands, wash your hands. Stay home when you're sick, and then wash your hands. Use Kleenex when you sneeze, wash your hands, wash your hands. So please do that, and that is the number 1 most important thing that you can do to keep yourself and everyone around you safe. Now, okay, so staff protection. So there's 3 things I want to tell you about what the staff protection working group is doing, and then I'll just recap it with what you can do besides wash your hands. So we are focusing a lot on mask fit testing. And we have a policy for mask fit testing. So we have a policy, we have always had a policy, and we've always had a program for mask fit testing. It goes on every single month in this organization. It always has, it still does. And we have a policy that says, essentially, I'll just boil it down for you. If you, in the regular course of your job, have to be present on a unit where patient care is provided, then you should be mask fit tested every 2 years. So in human resources, for example, you might not necessarily have to be mask fit tested every 2 years, but if you are a food services employee who delivers food to a unit, then you have to be mask fit tested every 2 years. So it's not necessarily your job or department, it's whether or not in the normal course of your business you are required to attend a patient care area. You should be mask fit tested every 2 years. If you are not in that category and you do need to be mask fit tested, we can mask fit test you, no problem. But the 2-year people are who we're trying to target. There's also naturally a priority sequence of people. If someone with coronavirus presents in this organization, it will probably be in the emerge. And so the emerge is our absolute number 1 highest priority. Every single person who works in emerge must be mask fit tested 100%. And we should be at 100% already. If someone goes to emerge, then they go to ICU. ICU has to be done. So you see how we've got a sequence, and we've been working through trying to target the highest priority areas in order. We have engaged a third-party service provider. The company's called Synergy. It's not important, but we have drastically opened up the spots available for mask fit testing, and we've basically set up camp in the Hennick Gallery. And until very recently, we were sort of inviting people in the priority sequence. We have now opened it up so that anybody who meets the criteria that I just said, if in the normal course of your business you have to attend a patient care area, if you have not been mask fit tested by us in the last 2 years, now is a very good time to do that. And so there's several ways that you can do that. We are letting the managers of all of the departments with staff who meet the criteria, all of those managers know what the schedule is. Please talk to your manager. They can sign you up for slots. You can go onto LMS and sign yourself up for a slot, search for mask fit testing. You can go down to the Hennick Gallery and do a drop-in. That works most of the time. Sometimes you might find that they have their 6 people full and you can't get in at that particular moment, but try it anyway. And we've got another little offshoot of the staff protection group that's just a mask fit testing group that is really looking at what is the absolute fastest, easiest way to make this most accessible for you at a time that is most convenient for you. So we're continuing to work away at that. But please, if you have not been mask fit tested in the last 2 years, and if you meet the criteria that I just mentioned, now's a good time for mask fit testing. Hennick Gallery, talk to your manager, look on LMS, go in, drop in, see if you can get in. Okay. That's mask fit testing. I also want to tell you that occupational health is really diligently looking at the staff who are returning to work after they have traveled to China. And I really need you to know this, and I need you to be able to explain this to your colleagues. So listen as if you're going to have to explain it to someone in 5 minutes, because you might have to. So we have had cases of staff returning from China. They went on a vacation, they went on a trip, they come back, they get screened by occupational health, they get returned to work, and it has caused some distress among the people who they work with because not everybody understands how closely we're looking at this. So all of the communication that's coming out from our corporate communications department, which is really thorough and it's really good, and it's also stored in that huge box on the intranet that says coronavirus resources in massive letters. All of the communication is in there. All of the information you need to know is all in there. So please check out the communication. And what it tells you is that if you have returned from China, and even if you're feeling well, and you probably are, then let us know in occupational health. Occupational health is going to ask you a series of questions. They're going to ask you questions about exactly where you traveled. They're going to cross-reference that with the case definition map from China. They're going to ask you where you traveled, how long you were there, who you're with, how you're feeling, how that person is feeling. Have you had any symptoms in the last 2 weeks? They're going to ask you a series of questions. Then occupational health is going to collaborate on every single case. They're going to collaborate with infection control, with the occupational health physicians, and with the people and culture portfolio. And we are going to then cross-reference everything that we've been told with what we are being told by the Ministry of Health, Public Health Ontario, Toronto Public Health, federal government, provincial government, name it. We are looking at all of the information all the time. And then we're making the very best decision that we can with the information that we have. And believe me, we have the most up-to-the-minute information. And we are returning people to work if it's appropriate. I can tell you that in 100% of cases, it has been appropriate. We have returned people to work. Then we watch those people every day for 2 weeks. And as soon as they're symptomatic, then we make a different decision. None of those people have been symptomatic, and everyone has returned to work very safely. If you hear any unrest or any anxiety at all about, oh my God, I work with this person and she just got back from China and I'm really worried, you can rest assured that this process, we have got this. This is an airtight process. And we are also aware that we are watching information and the information may change. So we are making the best decision that we can with the information that we have, and we have up-to-date information. When we get different information, we may change the way we do things. But right now, we're meeting all of the guidelines and all of the requirements, and we are very confident in this process, like Gary said. Okay, so that is people. Oh, and then one more thing I need to tell you. If we do end up in a situation where we have to close our doors to anybody but staff, and again, we are nowhere close to that, but if that does become the case, then we will restrict visitors, we will restrict volunteers, and only staff get in the building. And if that happens, then it is going to be extremely important that your badge, which I am not wearing, it's on my desk, is up to date, that it has not expired. They expire, check. And that it is legible and that your picture looks like you. So have a look at your badge. Make sure that it's not expired, make sure that your picture looks like you, make sure that you can read it, make sure that it's your right name, make sure that it's spelled right, all that stuff. And if this is not, Gary, is yours right? Gary's is perfect. Okay, good. So he's going to get in the building. So So if your badge is not up to date, legible, like a picture of you, then now is a good time to go get your badge. And the way that you do that is you go down to security on the first floor, and we have been assured that they have lots and lots of resources and lots of new badges, and it only takes a second, and they're very willing to help you get a new badge. I also just want to tell you that this is a very good time to just let you know that that it's kind of interesting. The reason they named this COVID-19 and not SARS or MERS or anything like that is because there was a very conscious effort to not attach any sort of geographic identity to this virus. And so the reason for that is because we don't want anybody thinking that there is any specific group of people who are responsible or who should be avoided or anything like that. And so I just want to take a moment to just remind you of our value of inclusivity and our value of humanity. And we are all supporting each other. We are all being we're just being open-minded, and we are all just making sure that we ourselves and the people around us have what we need to be able to do our work and to be able to provide great care for our patients. So I just want to remind you, just be kind to yourself and be kind to everybody around you. And I think I can invite Jenny and Kate for questions. Yeah.
Any questions? We'll do general questions at the end. Any questions on COVID-19?
What's known about the transmission of this virus, and how long would it, say, live on a surface on a phone?
So those are great questions. And, I do want to pause and comment about the fact that we've only known about this virus now for maybe 6 weeks. And the amount of information that we do know is incomprehensible, truly, and incredible. However, there are still several unanswered questions. So the one about the transmissibility, what we follow typically is something called an R0, which is the reproductive number, which is the number of people you infect based on if you yourself is infected. So for this virus, it's estimated, and they vary widely, and if you're not in a cruise ship or some sort of very crowded environment, it's felt to be somewhere in the order of 2 to 3. So for every infection that you have, in the absence of an infection control measure, that you're going to infect between 2 to 3 individuals. But for context, influenza is somewhere around between 1.5 and 2, and measles, which is our most infectious disease, is an R0 of 18. So, just to kind of provide some sort of context to it, it does appear slightly more infectious, or more transmissible, than SARS was, and definitely more than MERS, which are the other novel coronaviruses. In terms of, I don't know if this is the question you're asking, but I'm sure it's a question that many people are asking, is about the role of asymptomatic transmission, because that is a burning question that many people have asked. For those of you who may know, a few weeks ago there was a report of a person who had come from Shanghai to Germany and done an education session for auto workers, and they were in closed, contact for 2 to 3 days, and then returned back to Shanghai. It was a letter to the editor in New England Journal of Medicine, and in that report they said that this individual from Shanghai was asymptomatic and then spread to a number of individuals at that education session. That was retracted because what happened was the authors did not contact the individual who had returned to Shanghai, but it turns out she was febrile and was taking Tylenol, and so that asymptomatic transmission was debunked. And then that kind of went away for a few weeks, that sort of question, but in the last 24, 48 hours has resurged again. I was on a call yesterday with both the FAC, Public Health Agency of Canada, and as well as there was members of CDC there as well. And I did pose the question again because it's been again in the media in the last 24, 48 hours. And some of those asymptomatic individuals were the returning travelers from the Diamond Princess to the US. They said they are symptomatic. And so they said that the issue of asymptomatic transmission continues, but he said not these individuals. And so at this time, WHO, CDC, FAC Everybody is saying there is not asymptomatic transmission. Again, that is based on what we know today, and that information may change, but there are people who have minimal symptoms or low, a cold, and they don't have to have severe illness, but they do have symptoms. So that is what we know today. You said, and surfaces. So then the other, also on this call, the WHO has outlined 5 priority areas in terms of research questions, and the surfaces is one of them. So we don't have that answer today. I assume that it's similar to many other respiratory viruses that can survive on surfaces. And my personal opinion, when I'm reflecting on the Diamond Princess in particular, I think it's showing us that contact, sort of living on surfaces, is important. Yeah, so even though that viruses can survive, there isn't anything that we know of that is special about this virus. It's an envelope virus, and as far as we know, it's an easy to kill virus. So our regular cleaning disinfection should work. The key is, though, you have to do it. And so I think in terms of our processes, what we are doing a double clean, just because there are things we do not know, but we don't believe there's anything special in particular about the virus per se.
Any other questions? Thank you.
If you do have any questions, just so at the end of every communication that's coming out, there is a link that you can pose your questions to. Should sufficient questions come through around a topic, we'll add them to our FAQ document that's on the information and resources page. Thank you.
Thank you. We did not have the luxury of this type of pre-planning for SARS. This is completely different. Renew Sinai, what's that?
Morning, everyone. Just to provide a quick update on Phase 3A Renew Sinai. It's all around you. You can see it, you can hear it, and sometimes feel it. As of January, we reached the 50% mark of our project. So we've renovated spaces like the neonatal follow-up clinic at 700, the OPG building across the street, the new ophthalmology clinic at 60 Murray. Here at the hospital, we have the 20th floor rehab and well-being centers. We have the new labs on the 11th floor. On the 4th floor, we have a temporary EOPS. And in the basement, during level 1, we have new materials management, housekeeping, support services, and our health records. Currently, we have over 100,000 square feet of renovations underway. We have the new emergency department, the first phase, on the main floor. On the 7th floor, we have 65,000 square feet of renovations for the new surgery program, and much, much more.
So I think it's fair to say that almost everyone in this hospital is impacted by this project. And we just want to take this opportunity to thank you all for your support. We wouldn't have gotten this far without you. The finish line is in sight. And we know that we will need your continued support to get there. But would any celebration truly be a celebration if we didn't have cake? So, following the question and answer period, there will be cake outside. Thank you all.
We start with the cake and then find a reason. What's the box? Does anyone know? Like, is there a magic show at the end of this? Someone's office. And it's mobile too. It's excellent. That's excellent. So, question and answers. We have some solicited questions which we can work through, but before that, again, open floor. And this is open for questions about anything you've heard today or otherwise. Also open for comments or announcements or general shout-outs. And I'm told I should pause a bit longer, so I'm going to pause. It's both a pause and a moment of silence. Open questions. That's a good enough pause. Yeah. 10 seconds. I could have dropped something. Yeah. So we have a few questions, and we've actually quite intentionally not sugar-coated the questions to keep you here and interested, at least. I'm just reading them? Yeah. Okay. So question number 1. Make sure I've got it. Staff parking rates increase exponentially and seem to preferentially favor those with 7 to 7 p.m. schedule. Is there a possibility to review rates? So I'm going to introduce Stephen Goldsmith, who's our Vice President, Business Innovation and Development, controlling the elements of our institution, like parking, that are either done for profit comes back to the building, and big areas like Mount Sinai Fertility, so big clinical and retail aspects of our institution.
I like to say I'm the VP of causing headaches for Gary and the team. I'll probably get more questions about parking than we did about coronavirus, so happy to answer them. But with respect to that specific question, it was hard to exactly understand what the reference was for, but generally we ensure that we conduct regular analysis of the parking areas around the hospital. And with that analysis, we've got employee parking passes that we've developed. I know the pricing has gone up. We raised it in January, actually. We're still below market rates for the area, so we still believe it's a good deal for the area, and it's certainly better than the daily rate that exists. Our overnight price is significantly cheaper than the daily rate, so with respect to the pricing, but it's based on demand. Obviously, there's more demand during the day than at night. And our overnight and daily rates are comparable, in fact better than the local rates in the area. Beyond that, we do have a little known, we've tried to put the word out, but we'll be spending more time on this. We have an employee and visitor and patient parking panel that we have that anyone can provide their comments to. We've received a lot of questions about it, usually tied to pricing, but we'd love to hear more in terms of ideas of how we can make our parking lots better and more efficient and a better experience for our patients and our staff. So please don't hesitate to reach out to me or Lucy Oliver, who is our senior manager in charge of the parking lot. Should I ask them if they have any questions about that? No.
And just a quick follow-up to that. In Ontario, there is a rate for patients and families, and that rate is applicable for Mount Sinai patients using our parking lot, but it's also applicable for Princess Margaret and TRI patients using our parking structure as well. I do empathize and sympathize. It is not inexpensive to work in downtown Toronto, and our cost structures reflect that as well. But it's not done with any joy, and we debate the fees on a regular basis and do as good as we can. The second question, that was a warm-up. And again, they're not edited. Why do executives get year-over-year large increases while capping staff, asking others to retire and cutting positions? Staff are overworked and exhausted. So I'm going to break that up. Executive pay, this is just an FYI. Executive pay in Ontario, and that's defined as the CEO and anyone who reports to the CEO and who earns over $100,000 a year, is capped all in, bonuses, everything, and that cap has been in place for the last decade. So no executive, in quotation, legally gets a raise or can get a raise. When people change jobs, get new roles, new titles, new people reporting in, their pay reflects that, but the people you see in front of you year after year are receiving the same pay. I actually think that's appropriate for our province. We're provincially, not in an unchallenged moment. So that's an established and accepted approach. Staff, so there's two levels of staff in an institution like this. There's unionized and non-unionized. The unionized is very much, ONA as an example, negotiated provincially, and that sets the rate within our institution, and the increases are typically in the 1% to 2% range per year, based on the contract, based on the group. And again, that's set. That's nothing we do. We're coming into a period where the government has set in legislation a cap of raise of 1% a year that starts for us next year.
January 2021.
January 2021. So for the 3-year period, things cap at 1%. Roughly a third of our people are non-unionized, and generally, we try to be close to or match the amount that we give our unionized people to the point of affordability. Now, and this is going to talk into the retiring, cutting positions. So you will have seen that we put out an opportunity for different things. People who are leaving, and the position when they leave, we won't be using anymore, or we'll be doing at a different level with a package. We've offered people an additional week of unpaid vacation, and we've offered people to convert from full-time to part-time. When the offer is made, it's an offer to be considered. It's only accepted if it makes sense institutionally, meaning if someone leaves with a package and then we have to hire someone at the exact same price, then that person isn't applicable for the program. The point of how we pay our non-unionized people as good as we can, and what we're doing with all of these initiatives, is very much the sustainability of our hospital. Hospitals, like the education sector, are simply under siege. Operating budgets are very difficult. Balancing year by year is an enormous challenge. Our institution, because of the work of everyone in this room, the programs I've just talked about, and so many other things, performs well. We will balance this year. We'll have a big gap starting again in April, and we'll have a ton of work to do, rolling up our sleeves to get there. But this year we will balance. For 2021, we are not looking at service reductions, so we're not closing things in this institution. We are not instituting across-the-board cuts to all of the programs in the institutions. We're doing it much more surgically than that. The reason we're able to do it is, again, everything I've just said. We're distinctive in our sector, at least in downtown Toronto, where our peer institutions, and every hospital is the same, but every hospital is different with different challenges. But our peer institutions don't look like we do today. Most of them are not going to balance this year and have very large gaps, and several of them are looking at service reductions, closing wards, laying off people. We're not doing that. The question was asked by someone who's stressed, and we appreciate that, and we appreciate that it's not easy to work in healthcare right now. It's not easy to turn on the news and be basically almost assaulted with a barrage of difficult information about public sector in this province. So we're very respectful of people's stress, of their workload, and we're dramatically appreciative of people's participation and engagement. This is the best workforce in the city, if not the province. This institution is off the charts with efficiency and performance and with its quality. And that's all because of everyone in this room. We look at and we benchmark how we perform with things like executive compensation, and frankly, we're where we're supposed to be, which is we're below the median for our sector. So we pay, as a group, our executives less than our peers, and that's a comfortable place for us to be. So, this is why we have cake at the end. You gotta have cake. If you're feeling stressed, we get that. But please, kind of like coronavirus, where we hopefully reassured you that the institution cares, is passionate, and is working relentlessly for safety and to make sure we deliver the care we do the right way. I want you to also take home the same message in terms of our financial performance and how we organize and manage ourselves. We know we're a shop of people. We know that you're on the front line, and everything you do only occurs when you are well and you're not stressed, and we know how hard that is to be at. But please at least be reassured that you're working in an institution that cares about all these things and is trying to do the right things financially for our patients and for you. Final questions. I'm checking because I don't have a watch anymore. Okay, so we're at 12:34, so thank you very much. Lovely turnout. As you go out, so that everything gets solved with a piece of cake. So as we go out, please get a piece of cake, and thank you very much.